Hello, everybody, and welcome. My name is Tim Heimgartner, and this is a Capstone preparatory assignment on presentation for my upcoming Capstone project due next quarter, which is titled An Institutional Guide and Suggestions for a PE Response Team, also known as a PERT. This is for HTML 465. Let's go ahead and get started. So what is the objective of a PERT? So if you guys don't know, pulmonary embolism is what PE stands for. And PE is a disease in which clot or thrombus, which usually starts in your lower legs, either below the knee or above the knee, in what is also called deep vein thrombosis or DVT. It's a blood clotting condition where the blood clots dislodge and become transient and go up through the right heart and get lodged into the pulmonary artery outflow. And what that does is it causes a couple issues. It causes deoxygenated blood not being able to return to the lungs proficiently. And it also causes a lot of back pressure, which swells the right ventricle. So the objectives of this PE response team is going to be to develop a rapid, evidence-based, multidisciplinary approach to treating PE disease state. And what we're going to do is establish kind of the level of risk, also known as risk stratification of these PE patients, to determine who is best to be treated with either advanced therapies or minimally invasive therapies, or even just unfractionated heparin and just monitored on the floor. So that's going to be the real goal of this PERT objective. And lastly, the main objective that all hospitals want to look towards accomplishing are going to be to improve quality outcomes, which means reducing treatment delays for PE patients and lowering what is inpatient mortality or inpatient deaths attributed to PE. Now, when we look at the PE patient population, it's kind of segmented into three different areas. Minor PEs are the patients that come into the emergency department at just kind of are short of breath. That's 55% of the PE population. They usually do pretty well. They usually are put on blood thinners. Some of them aren't even really admitted to the floor. Some of them are just given Lovenox or discharged. They have a very, very low mortality rate. A lot of people that have minor PEs probably won't even know that they had a PE, and the body just kind of self-lyses that clot. The other two categories are going to be massive PEs, which are the smallest pie of that, smallest percentage of that pie, and that's just roughly 5% of the PE population. And these are patients that will collapse upon episode of having a major PE. They usually have a pretty poor prognosis with a 58% mortality at 3 months. So these are the patients that sometimes they don't even make it alive to the emergency department. They usually pass away in the field. The other, and what is going to be called the submassive PE population, is really the population that this PE response team is looking to improve quality outcomes with. These are the patients that they're not massive, but they're definitely not stable. The European guidelines call them intermediate risk PE, and that's roughly about 40% of the PE population, so a good percentage of them. Now, they do have a fairly high mortality rate of 21% at 3 months. These are the patients that are admitted to, say, the ICU and might just be observed for a day or two in the ICU by a pulmonologist or intensivist, and really there's really no definitive treatment protocol for what to do with these submassive patient populations. And if you look to this chart on the right, it just kind of shows the downward spiral effect that patients can go through if they have a PE that goes undetected or goes untreated. You get, right ventricular wall dilatation. You get increased demand for oxygen by the lungs. The RV starts to swell. The myocardial fiber starts to stretch with the heart. And what can eventually happen is you go into cardiac arrest or cardiogenic shock, which ultimately leads to death. So the whole purpose of this PE objective, PERT objective, is going to be to eliminate those patients that may be headed towards this downward spiral effect and be able to catch them earlier and be able to get them the proper treatment necessary. So what is pulmonary embolism? The incidence, it's pretty prevalent, 69 cases per 100,000. There's about, so the other interesting factor is it's responsible for more deaths each year than breast cancer, AIDS, and traffic accidents. It is fairly common. And what we really want to look for when we're talking about PE is what is called right heart dysfunction. Now, I mentioned it earlier, and that's when this blood clot gets trapped in the pulmonary artery and it causes a lot of back pressure. The right ventricle of the heart is not used to being stretched or dilated. It does not like to be under extreme pressures. That's where you get a lot of your complications from. In fact, RV hypokinesis, which is enlargement of the heart, is associated with a 50% higher mortality rate, even when patients that are stable. So these are patients that blood pressure is normal. They still have a 57% higher mortality rate. As that right ventricle starts to swell and get bigger, and you can see the CT image here in the lower right-hand corner, as that right ventricle starts to dilate larger, it's an independent predictor for mortality. So as the RV-LV ratio goes up, anything greater than 0.9 is an independent predictor for increased mortality for these patients. The strategy for implementing a PERT program is going to be, this is a guide that I'm going to develop so institutions that want to address the PE disease state in their hospital can use this as a kind of a recipe or a guidebook on how to formulate their own PE response team. So part of that is going to be identifying the necessary stakeholders within the institution that want to be a part of the PERT program. And we'll cover who those players are here in the next slide. The initial step is going to be to develop a charter, a working charter of what expectations are of team members and stakeholders. What are the overlying goals of the PERT? What is the institutional goal? It may be to address treatment delays. It may be to improve quality outcomes. Those will all be determined in the initial meetings with this PERT multidisciplinary team. The other strategy is going to be to develop a PE risk stratification chart that all clinicians within the hospital can follow. This will be an agreed upon chart, and it'll be also a published PE algorithm. And there's a little bit of an example just below here about a PE risk stratification for patients that are in those three groups: massive, submassive, and then the minor PEs. And then the end result is going to be we have what is called a PERT activation team or on-call team, where the ideal situation is going to be where patient presents to the emergency department with shortness of breath. They're going to have blood draws that indicate what their biomarkers are. They're going to have their blood pressure. And so you have these risk stratification elements listed here below that show if these patients have any of these criteria, if they meet these criteria, they're going to be lumped into this kind of risk stratification chart. And from there, the PE response team can make a better clinical decision on that patient's treatment and care pathway to the institution. This is what a pulmonary embolism response team typically consists of. It's going to be a multi-collaborative approach between interventional cardiology or interventional radiology. Those are going to be the main procedural docs if that patient needs to go get, say, mechanical thrombectomy or some type of advanced, minimally invasive surgical procedure. The intensivist or the ICU doc, who could also be a pulmonologist, will be the other important key player involved on this PE call team. Another important key player is going to be a cardiothoracic surgeon, also known as a CT surgeon. Could be a vascular surgeon too, someone with experience in doing open embolectomy in cases where maybe the OR call team or cath lab call team may not be readily available and this patient's clinically deteriorating. It would be nice to have someone who can do an open invasive cut down and extraction of that blood clot, especially in a patient that has cardiogenic shock or is coding. Pharmacy, inpatient pharmacy, since we're going to be using dangerous drugs like TPA, tissue plasminogen activator, we're going to have a pharmacy involved, and then of course the allied health support staff of the cath lab team or IR team. Moving on, this is a PE sample protocol. This is kind of what things are going to hopefully get steered towards, is a published institutional algorithm where you can, whatever your situation is, if you're a hospitalist or emergency med doc, if you have a PE that's confirmed via either CT or ultrasound, you can follow these steps here in this algorithmic chart to get an answer or a solution as to what you should do with that patient, who you should call and who you should consult. To the right here is going to be kind of the same thing as who are the players involved and what is the patient's care pathway throughout the institution. So why am I interested in this subject? Well, I think if you look back historically, we've done a great job of addressing heart attacks, also known as STEMIs, with cath lab teams doing, addressing that patient population with reduction in door to balloon time or door to intervention time for some of these patients that are having ST elevations or heart attacks. Also with stroke patients, we've done a great job with identifying stroke when it comes to the emergency med department, getting them a CT, getting TPA on board, and eliminating some of the adverse events that are accompanied with delays in stroke treatment. So PE has been an underserved patient population for quite some time. We've only really had two drugs since the 1950s, heparin and systemic TPA, to really throw at the PE disease state. Although new advanced therapies have come on board in the recent years that a lot of hospitals have not really adopted yet. They're still kind of stuck in the old ways of just either heparin or TPA. And my experience as a med device rep working in this arena of PE disease state has also sparked a lot of interest in me wanting to kind of head to this direction on my Capstone project. There's just been an unmet need for PE patients too, so I believe something like this could be helpful for, say, a small tertiary hospital that wants to improve quality outcomes with their PE patients, and use this as a resource guide for developing their own. The courses that I think from the HCML program that would be applicable for this Capstone project would be like project management, healthcare economics, reducing costs, patients associated for sitting extra days in ICU. I mean, there's some data that I can present that shows reduction in ICU length of stay for some of these PE patients. And then just improvements in institutional quality management. How are things going to be measured? Well, it's all outcome based and driven by outcomes. So the success of this program is going to be derived by how many PERT activations the institution is active, how many activations per month. If we see those go up, we know that we're getting more attention and more eyes on this patient population, more consults. Of course, we don't want every patient, even the minor PEs, to have a PERT team consult, but at least we're starting more dialogue and more communication around who should be treated for pulmonary embolism. And we can look at reduction in the treatment delays. So patients that sit on the ICU or sit for days without any therapy given or administered. And then also, since PE is the #1 inpatient cause for mortality for hospitals, we want to look at reduction in mortality from PE pre and post implementation of a PERT program. And then lastly, the last two are going to be improvements in quality care and reduction in hospital readmissions. There's some data that shows patients with pulmonary embolism that are discharged with their right ventricle still swollen or RVD are 8 times more likely to be readmitted to the hospital if that's not improved. So these are all interesting caveats to what can come and transpire from development of a PERT program. I'm highly enthusiastic about this project. I got a lot of great ideas, and I look forward to reading and sharing looking into everybody else's presentations as well. Thanks.